Hello and welcome to the multi-level health information modeling tutorial series.
So, as we've seen before in multi-level modeling, the main goal is bringing back the context to healthcare information. How do we achieve that in multi-level modeling? The main idea about the multi-level modeling approach is not making the information remaining incarcerated in the software. In traditional modeling, we know that happens because the context is hard-coded in the software when the data model is defined for a certain healthcare application or for an electronic medical record. And that doesn't happen in multi-level modeling. The software doesn't keep the information incarcerated. That happens because what is really implemented in software is the reference model. And the reference model, as we have seen before, is composed by those legal pieces, those generic classes. And in the MLHIM approach, those reference model classes, they were defined in such a way that they contain as minimal context as possible, but they don't go so far away about not containing any context, because the reference model is not a programming language. There is always a minimum residual context in order to allow building any type of healthcare application and persisting any type of healthcare data. So where is the context? The context of the information is not implemented in the reference model. It's contained in this other level of the application. Is contained in the domain models. The domain models are the data models that are defined for the library of concepts. So in OpenEHR in 13606, those domain models are computational artifacts that are called archetypes. In LIM, as seen before, those domain models are known as CCDs, concept constraint definitions. And something very important is that since they are based on the same reference model classes, they are just combinations and constraints to those reference model classes. They can be interchanged between applications, between systems, and they will be still semantically valid in all applications and all systems that are based on the same reference model. In consequence, information can be collected at the point of care, and the context that was present at that specific moment of history will be persisted, and it will last forever. Since the reference model is stable, that means that as long as the reference model is maintained, the information will keep its current semantic context, the semantic context that existed when that record was registered. even if the reference model evolves, since the information will be labeled, that data instance will be labeled that with a specific CCD or specific archetype. Let's think about CCDs. That data instance that was persisted according to a certain CCD or to a certain combination of CCDs, those CCDs will refer to a certain version of the reference model. Since this reference model will be kept historically in this longitudinal record, that information semantics can be retrieved even if now the current system is using a new version of the reference model. And so the content of the information is not affected anymore by changes in the software. The software can change as much as necessary to keep track of the domain, the dynamics of healthcare information. It doesn't matter. The concepts can evolve. The space complexity can be present. The temporal complexity can be present, and that doesn't affect that specific data instance that was created in a certain point in time, because it will be always referred to the domain models that created them and to the reference model to which those domain models were based on. And so what's more important for semantic interoperability between systems is that those information extracts that contain that original context, that will be properly space and time referenced, can be shared to any other application. If they are based on the same reference model, that information extract will be understood, will be semantically valid on the other systems. The history of multilevel modeling can be summarized in this timeline. Over the last years of the 20th century, in Europe, the Good Electronic Health Record project was launched and evolved and became the Open EHR specifications. At the same time, in the United States, an independent inventor, Timothy Cook, developed the trusted open source records for care and health. Both the OpenEHR specifications and the Torch application, they were based on the same idea of separation between the reference model and the domain models. At that point, Torch didn't use those terms, but the whole idea is still there, and it's implemented in software. In the turn of the 21st century, Tim Cook was introduced to the OpenEHR specifications, and he decided to join the efforts of the OpenEHR Foundation. And so for many years, as a volunteer, he gave contributions to the architectural review board of the OpenEHR Foundation, and his whole idea was trying to harmonize the ideas that he developed on Torch to OpenEHR in order to make the specifications possible to be implemented. At the same time, the OpenEHR Foundation goes to the ISO and negotiates the 13606 standard family. The 13606 is the results of trying to make the OpenEHR specifications as it is a standard. But the compromise that were made over this process inside the ISO made the OpenEHR reference model to become much smaller in terms of number of classes, and it lost most part of its context. In 2009, realizing that the OpenEHR specifications wouldn't become as harmonized as desired to the torch ideas, and by the fact that the National Institute of Science and Technology Medicine, assisted by Scientific Computing here in Brazil, funded the research lab that now is the MLHIM lab to start developing research in multilevel modeling. The conditions to launch MLHIM, those MLHIM specifications were present, and so MLHIM was launched. In 2012, what we can see is that the OpenEHR specifications, more and more you will have researchers trying to implement applications based on OpenEHR, and in order to overcome the complexities of the specifications, more and more there is a convergence, a net spontaneous convergence of OpenEHR to some of the original MLHIM ideas. And at the same time, the ISO 13606 is reinventing itself. There will be a review of the 3606 standards family inside the ISO.